Hello, everybody. It is July 22nd, 2020. It's 8 p.m., and it's been a while since I've done a vlog. A lot has transpired since our last vlog done on COVID-19. I'm a concerned Dr. Miskoff, and tonight I'm going to talk about some of the updates and how we're kind of managing COVID-19 today compared to previously. A lot of it has evolved, although really the treatments themselves are relatively similar to a month or two ago with a couple caveats. I just was hooked up with Michael Doyle. He owns a production company and does the vlog Be Inspired, capital B, and then Inspired, great series of podcasts talking about different inspirational stories, and we just did a double segment on COVID-19. We talk about also my recent loss of my mom to COVID-19 and how difficult that was. So those aren't ready for, they're not out there yet to view, but should be pretty soon, I guess after some edit. So anyway, check that out. My brother-in-law, Michael Farraher, knows him a long time, and my sister, Barb, and they introduced me to Michael Doyle, and what a great guy and what a great thing that he's doing to get the word out about different, again, inspirational stories. So anyway, tonight I'd like to talk a little bit about, again, the updates on treatment and workup, if you will. In regards to antibodies, the IgG antibodies that can be checked for, some mystery there. A lot of people that, believe that they had COVID-19 are testing negative, and in fact, they may not have had COVID-19. Although I do know several people now that were positive for the antibodies several months ago, and then on recheck are actually negative, and I'm not sure exactly why that is. Is the immunity, the quote immunity, wearing off? Is it just dropped under a certain level cutoff that the labs are checking for? So we don't know, but I think the assumption should be, until proven otherwise, that you don't have immunity if the immunoglobulins have gone away. You may, in fact, again, have some, and it's just that measurable level that the labs aren't picking up on. But I wouldn't make the assumption that you're absolutely immune to it, and would still take precautions and be careful. Happy to report that the numbers are way down at our local hospitals in Monmouth and Ocean County, at least, New Jersey, and the hope, again, is that as we get closer to September 1st, that the numbers will continue to drop. Right now they're peri 10 at our bigger hospital and under 10 at our smaller one. And I know the other surrounding hospitals are at low numbers as well, at least so I hear. Again, I will feel safe letting my son go back to school and going out, socializing more when I see zero admissions to our local hospitals, and that's what I'm looking for. Because to me, it's sort of night and day, black and white in regards to, if you have still a couple cases floating in, then that means it's in the community, and you're going to see micro spikes. And I don't see how they can justify keeping the schools open if they're seeing, kids bringing it home to families. If they don't see that, fine. But I think we'll know that within, 2 weeks of the school season, if in fact they are open and the numbers are low enough. But I want to see zero admissions to both hospitals that I go to prior to feeling, at least there'll still be a risk, a relative risk. But, again, when you get in your car, there's a risk. When you do basic things, there's always a risk. So in my eyes, it has to be at the lowest possible risk we can have. Again, that's in regards to admissions. Treatments, Dr. Bartlett out of West Texas got some recent press, a lot of press actually, for claiming that budesonide, which is an inhaled nebulized steroid, could be the silver bullet. I don't think we can claim anything's a silver bullet until we have, large randomized controlled trials, although it's curious. I believe he had 11 or 12 outpatients he had treated. He was stating that none of them progressed to hospitalizations or to severe. None of them died, at least it was claimed. So that's good news if it's true, but again, we do need bigger studies. Unfortunately, sometimes the outpatient early studies with some of these generic medications just aren't happening with any robustness, because there are large trials going on with expensive, powerful medications for severe patients. And let's be frank, big pharma, some of the companies I really like, and they do amazing things. However, they also have an angle. I believe if they are in fact, coming out with vaccines and monoclonal antibodies and chemotherapies that are used for cancers and HIV disease, these things may actually work. But a lot of energy and money is spent on them, where maybe a generic drug like budesonide nebulized, which would be way less in cost, although some people do have high copays even with that. Nebulizing this twice a day, he's claiming at least, is basically knocking out the pneumonia component. Again, this pneumonia likes to kind of hang out at the edges. Sometimes it picks one side versus another, but usually bilateral, at least in the severe forms that we see. Sometimes it's just a mild opacity or infiltrate on one of the lungs, and a more significant one. It likes the periphery. We think there's blood clots involved at least the microvascular level, and maybe even lipids. And recent news on Tricor, an older product for triglycerides and cholesterol. Mount Sinai in conjunction with Israel, I believe, recently got some press that even quoting that this could be, reduced to the level of a common cold. That would be great news, and it makes sense, when they're doing autopsies and finding blood clots and finding maybe some fat or lipid molecule in the lung tissue. If you could reduce that lipid burden, it at least makes sense, and a test tube would work. Whether this is going to, go to fruition in adults or patients with COVID is still debatable, but I think they are looking at that. Not suggesting in any way that we just randomly put people on these medications, although I have a lot of experience with budesonide, the nebulizer for asthma. It's FDA approved for that. We use it in combination with a product called Symbicort made by AZ, and great product for asthma and COPD, and has budesonide in it. But is the meter inhaler enough to really get it to the periphery of the lungs? Do you need a nebulized form to get it out where COVID seems to like to live? Certainly, I have been writing it for outpatients, remembering that in inpatients, there was concern about giving nebulizers in the rooms, that it would aerosolize the particulates, the respiratory droplets more, and put staff at risk. And there may be some truth to that. I think it was overblown a little bit up front. Kind of every hospital was adopting that, and now we're seeing some drift effect as there is some anecdote for budesonide. Again, no large randomized trials, not making any claims that everybody should be on this, but it's worth a consideration, I think, at least, being that we have large safety trials for asthma. It's FDA approved for children, and the risk of giving low-dose steroids, of course, in the beginning, talking about the ACE2 receptor upregulation with steroids and nonsteroidals, I think, again, was overblown a little bit. And the British study coming out with dexamethasone or Decadron, 6 milligrams for 10 days in a pill form if they can't take pills IV, showing mortality reduction, the only medication at the time to show mortality reduction, also waiting for remdesivir updates. So what's the current cocktail on the more moderate severe patient inpatient? At the hospital admitted with pulse oximetry or oxygen levels that are dipping into those lower 90s, as we've discussed on previous vlogs, would be, again, you check that D-dimer up front, low threshold for giving Lovenox at therapeutic doses, but if they're in the few hundreds, usually giving them about 40 sub-Q daily. Noxiparin, some hospitals are using sub-Q heparin more frequently, some are using heparin drips. That's all debatable as to which may be the best. I guess time will tell when we look at different systems in countries who used anticoagulation. I think most people are using anticoagulation for COVID at this point on the inpatient severe cases, or more moderate severe cases, tracking that D-dimer on a daily basis. So I think Lovenox is sort of locked in, at least in our system, in our practice. And whether we give 40 a day versus 1 milligram per kilo, twice a day as a therapeutic, more high intensity type approach, or more therapeutic approach, is up to the clinician, and no absolute proof as to how to manage that. But we do tend to follow those dimers and move the drug up in dose or frequency, or both, depending on how they're doing clinically. If they're worsening, even if the number is not going up, some of us have chosen to go to the therapeutic dosing. Remdesivir, no-brainer. Most hospitals haven't had problems getting supply. There was some concern about that. Gilead really has done a nice job, in my opinion at least, supplying that to at least our hospital. I'm hopeful that all the hospitals are getting it at this point that need it, or at least they can be transferred nearby to a system, a bigger tertiary care hospitals in the system that can provide it, or it can be transferred from those bigger hospital pharmacies. There are ways of doing that. So remdesivir, no-brainer, at least for 5 days, sometimes extending that to 10 days, IV daily. Looking at those liver functions, if they bump, obviously having to hold it, and creatinine clearances, looking at that as well. If you have bad kidneys, may not be a candidate for remdesivir, but most seem to be, especially if those pulse oxes, again, requiring a little bit of oxygen in the low 90s, under 92, 94%. That's what we're looking for. Remdesivir does have some data. There'll be more definitive data published in the future, but does seem to have a clinical benefit at this point, again, early. And will they have a pill form by next season to give to the early outpatient, less severe? My hope is that, yes, that's true. And how we follow them in clinic type settings will be curious and interesting, but I think we'll figure it out. So remdesivir, Lovenox, or other anticoagulation, those two seem to be kind of locked in right now. Plasma, again, a lot of availability for us. We have not had a shortage. It seems like the U.S. at least has done their job in the New Jersey area for sure. In New York, we're getting convalescent plasma. We have not had significant delays. Great job there. Again, probable data to come out with some benefit, I think, but you get mixed views on it. And it's like, patients are getting multiple therapies, and it's hard to say which one is actually doing the best job. Right, you're on remdesivir a few days, you get plasma, you feel better the next day. Which one was it? In addition to maybe trying budesonide on that inpatient, but that's again up to the respiratory therapy departments, and obviously looking at safety and aerosolization. With that said, hospitals do have access to different types of nebulizers, ones that are more actuated by the patient, and that would be, I think, the way to go. Could give them Pulmicort or one of the other inhaled corticosteroids. Most hospitals have inhaled corticosteroid and long-acting beta agonist combos on formulary, but is that inhaler enough to get it out to the periphery to actually get rid of COVID, or at least reduce the inflammation? So again, Lovenox or anticoagulation, remdesivir, plasma, maybe nebulization will be helpful. I guess this is the at least start for these patients when they come into the hospital. And then if they get sicker, the anti-IL inhibitors, the IL-6 inhibitors can be considered. And some hospitals are using, again, other chemotherapeutics, mAb drugs. These types of things are being studied. Some concern about secondary infections, of course, with Decadron, the 6 milligrams, which again is part of that initial cocktail now. Showing evidence out of England that it could decrease mortality. So you don't want to give too many immunosuppressants in that high-risk patient, right? Like my mom who had COVID, she kind of got through that part, and we'll talk about that more in other segments, but then got the anti-IL-6 at some point when she had gotten more severe, and then unfortunately succumbed to a MRSA infection that got into her bloodstream and had difficulty clearing that to the fourth blood culture. In the older population, the ones that live in nursing homes, in long-term care facilities, and hospitals, in and out, that are on chronic immunosuppressants. Again, we're leaving hydroxychloroquine out of this conversation right now, but those patients, I think we may look back at it and say, that subset was the higher risk ones, that you avoid those. And hopefully with the cocktail we just described, you don't have to even get there, but no guarantees yet. So I have some reluctance with the bigger immunosuppressants. Acalabrutinib is being studied through AstraZeneca. Seems to be very well tolerated, at least in those oncology or hematology patients with leukemic processes. Abrutinib, next generation acalabrutinib. Again, when I talk to my oncology colleagues, seems to be very well tolerated as a PO agent. This is along the lines of some of the other interleukin blockers. So interesting there, and we'll see as those studies get completed and published. In the beginning, we were just doing whatever, trying to avoid steroids. Now we're giving them. The anticoagulation part we figured out early, we think, although time will tell. Anything I say tonight is with a disclaimer, right? There's no yet definitive stuff out there, maybe Decadron, and all these other things are experimental until we have the big trials. So they're used with, a warning and a caution in regards to safety. I think we'll stop there for tonight. I hope to be back soon. Again, check out Be Inspired podcast by Michael Doyle, and hopefully that will be ready and edited soon for viewing. And we get into some of this stuff, but more generalizations about safety and other things, tracing and some of the topics that go along with COVID, and a little bit about mom as well. So I guess I'll dedicate this episode tonight to my mom. She's definitely in a better place, and it was one of the hardest months I had, and I thank my team and all the healthcare providers that helped me take care of her. Definitely emotionally charged, and it was tough. We'll talk about that more later. Everybody have a great night.